I thought that since we are approaching the start of the school year, and since next week, I think we're going to have presentations focusing on school interventions to reduce transmission. And we're also, as we've discussed, kind of on the precipice of probably another surge of cases coming in the fall and into the winter. I thought it was a good time to review what we know about the epidemiology, of SARS-CoV-2. We've had now almost, over 2.5 years to study this virus and the variants of this virus that have been coming our way over the last several months. And there's a lot that we don't know, obviously, about the virus, but there's a lot that we do know, and particularly about the epidemiology. And that's, I think, important to keep everybody refreshed on that as we go into the fall and anticipate some additional challenges that we're going to face. So I think the first thing to recall is transmission dynamics of SARS-CoV-2. And we know now that this virus is primarily transmitted through the air. It is transmitted by various droplet sizes that are emitted from persons who are infected. Some of those droplets are relatively large, and the droplets that are greater than 5 to 10 microns in diameter tend to fall out through the action of gravity over a short distance. But those particles that are less than 5 microns and less than 1 micron essentially behave like a gas and can transmit over very long distances and can stay suspended in air for very long periods of time, which is why indoor environments, and especially enclosed indoor environments with poor ventilation, are such higher risk. So again, I think important to remember what the major risk factors are for transmission. We know that surface transmission is probably greatly overestimated. It certainly has been previously in the epidemic. And so I still see people taking incredible precautions to wipe down surfaces and doorknobs and things like that. And certainly I think that's not a bad idea. But at the same time, these people aren't wearing face masks, which is obviously the largest factor for protection that you could do among those different choices. And we know that transmission, or the shedding of virus, is also dependent upon activities of the person who's infected and shedding virus. And so virus is shed even during normal, relaxed breathing, but shedding goes up significantly when people vocalize, and the more they vocalize and the louder they vocalize, the more virus is shed. And that's why an indoor room of people sitting quietly breathing a normal tidal volume is much different than an indoor room where people are potentially exercising and breathing at a much higher tidal volume and expelling air at a much higher velocity. And then when you get into talking and singing and yelling, those things increase transmission potential even more. And you can see there that there's many logs of difference between just breathing and then going to talking and then going to singing. And that's why those types of indoor environments where people are unmasked, speaking loudly, yelling, singing, and that is things like bars and restaurants particularly, can be especially high risk. And also probably the explanation for why, when UNMC researchers did testing in schools, that it was the choir rooms that were inevitably the ones that had the highest number of hits for environmental sampling. So these indoor environments where these virus particles, or these small droplets that contain viruses more appropriately, can build up when ventilation is poor or inadequate. And again, to reemphasize, these are not individual virus particles floating around. They are small droplet nuclei suspended in the air that contain virus within. But those particles will build up if rooms are not well ventilated. And you can see on the right, that figure demonstrates an indoor environment where there is very poor ventilation, and you can see the density of those virus containing particles builds up at that point. You can see that even though this person is well beyond the 6-foot rule, that this person still has significant exposure. Now, if this person with the circle, the halo around their head, demonstrating, I think, the air that they are breathing, if they were move closer to that source patient, the female icon by the door, you can see those large droplets would come into play, and exposure would be greater. But I think it's a misconception that if you move beyond 6 feet that you are somehow safe. You're not, again, especially in an indoor environment with poor ventilation. Now, if you turn on the ventilation system and you create air exchange with fresh air, now this is not just air that's recirculated, because that's bringing the particles back into the room that were just expelled. But if this is fresh air that is being brought in, or it's air that's going through a HEPA filter before it's recirculated, then you can see you dramatically reduce the density of particles and the exposure that person is encountering. This is another representation of that, and it just shows that it is not only the concentration of virus that you are exposed to, but it's the amount of time that you are exposed to the virus that makes a big difference. And I think that is obvious in the figure to the right, where those various lines represent different risk scenarios. So a meeting in a room with a person with 6 others or 10 others or 20 others, but you can see that there's a significant time dependence to when somebody becomes infected. And again, important to remember that exposure and infection is not a binary process. You are not either exposed and then inevitably going to be infected, or not exposed and not infected. You are exposed to a certain amount of virus, and it takes a certain number of virus particles, which is probably different for every person at every given point in time. And we don't have great knowledge of what exactly that average infectious dose is, but it's a lot more than one virus particle is the bottom line. So the more virus particles you're exposed to, the higher your probability is of being infected. And also true that the more virus particles you're exposed to, probably the more severe your case of SARS-CoV-2 is going to be. So if you are infected with, let's say, 5,000 virus particles, you may have a relatively mild case of COVID and recover quickly. If you're exposed to 5 million virus particles, that increases the odds that you're going to suffer a more severe course. So again, time and exposure matters a whole lot. And that's why reducing the concentration of virus you're exposed to makes a big difference, but reducing the amount of time that you're exposed to that concentration is equally important. We also know that epidemiologically, as viruses have continued to change and go through new variants, the transmissibility of these viruses has gone up. Now, certainly relative to each other, we've been able to compare pretty accurately the transmission advantage that Omicron had over Delta, and that BA2 had over Omicron, and that BA4 and 5 had over BA2. Now, important to keep in mind that those things are all relative for the given point in time, and the population immunity in the environment that those viruses are circulating does not necessarily equate to a head-to-head comparison of these viruses in a perfectly naive population. However, it does appear that even that basic transmission rate, or R0, seems to be increased for these new variants compared to the original Wuhan strain that you can see down near the bottom, which probably had an R0 of around 2.5 to 3. We think now that some of the most recent viruses like BA2 and BA5 may have R0s that are even higher than 10. I think some of the estimates of 15 to 20 are, I think, exaggerated quite a bit. But certainly these are some of the most transmissible respiratory viruses that we've encountered with these latest variants. And that's important to recognize that we're not dealing with the virus that we dealt with in the spring of 2020. The virus we currently have is much more transmissible. We also know that the virus moves through populations and communities in a nonlinear fashion. So it does not, because you're if your R value on average is 2, it doesn't mean that every person who's infected transmits to 2 people. It means that most people who are infected actually don't transmit to anybody, but a small proportion of those who are infected transmit to a lot of people. And you can see there on the right, that's kind of that, people have called it the 80-20 rule, or some have called it the 80-10 rule, but roughly the data seem to suggest about 10% of people who are infected end up being responsible for about 80% of secondary cases or onward transmission. And these are these super spreaders, right? So again, most people who are infected will not transmit to anybody else, even family members. And then many who do will transmit only to one person or maybe 2 people. But there's a small subset, again, this 10%, who may end up transmitting to 5 or 10 or even 30 or 40 people in these super spreading events. And that's how the virus moves through populations. So the more opportunities you give for super spreading events where you have larger groups of people in congregate settings, the more effectively the virus can move through the population. We also know that now the epidemiology, again, much different from what we saw 2 years ago, where essentially everybody in the US has been infected with this virus at least once. Now, the latest population-wide surveillance data we have from the CDC is from February. And I've talked about these data before. This comes from their seroprevalence in commercial laboratory system. And in February, so after most of the Omicron wave had passed, but before BA2 and before BA5, you can already see that 60% of the general population had antibodies against the N protein of SARS-CoV-2 that can only be obtained through actual natural infection. And that in kids, it was over 75%, and in more recent data that came out of this network for kids, it's well over 80%. And so that's just people who have antibodies against the N protein. We also know from studies that those antibodies decline over time, and that there's a good proportion, 10 to 15% of people who never develop those antibodies after documented infection. And then after about 6 months, about half of the people who did develop antibodies are below detection level. And so we've talked about this before, but this, I think, demonstrates the fact that, if 60 to 70% of people have antibodies against N after 2 years or so of the pandemic, it means that everybody almost certainly was infected at one point, and we're just not able to find antibodies in a subset of those people who were infected. The next thing I think that's important to recognize is that shedding dynamics have changed among people who are infected from prior variants. And it seems to be clear based on multiple studies that patients infected with Omicron, with BA2, and now BA5, even more so, are shedding virus for longer periods of time than were previous infections and previous variants. And so this study, just published a couple of weeks ago in the New England Journal, looked at 30 some odd patients with Omicron and 30 some odd patients with Delta variant treated in the Mass General Hospital or Partners system in Boston. And it showed, as you can see here, even with virus culture, right, which is a pretty high bar, it's harder to culture virus, obviously. And if you have virus that's culturable out of your nose, you clearly are infectious because it grows much more readily in people's respiratory mucosa than it does in virus culture systems in a laboratory. So again, at day 5, 53% of people in this study still had culturable virus detected in their nose. And that obviously seems to make the current CDC guidance of 5 days of isolation seem pretty silly when you think that half of the people at that point are still highly infectious, shedding culturable virus. And even at day 10, you can see that a relatively significant proportion, right, between 15 and 20% are still shedding culturable virus with Omicron. And that's different from what we saw with Delta, as you can see there, and with previous variants. So last thing to remember is this principle of exponential growth that we've talked about before, right? So any intervention you make early on is tremendously amplified as you go through multiple generations of cases. And that's why things that have relatively small impact over time can have a significant effect on the course of an epidemic. We talked about the quack virus long ago, and how just making half of the population immune, which is not a great vaccine effectiveness when you think about it, but can have a huge impact multiple generations down the road. So if you look at this theoretical population with half of the population immune and taken off the board compared to full population susceptibility, you can see that after 10 generations of cases, if you have an R of 4 compared to an R of 2, it's the difference between 500 cases and 260,000 cases. So those relatively imperfect interventions, like a vaccine with only 50% effectiveness, can have huge epidemiological impact as the epidemic continues to grow. Here's where we are now, and this is essentially our set point going into the fall. You can see that we've been at a plateau of daily cases for quite a while now, a couple of months. And we seem to be relatively stuck at that point. But you can also see that our hospitalizations have been going up consistently over the course of those few months. We may have plateaued. We may be going down slightly in hospitalizations, hard to say, but I don't think we're going to go down tremendously. And you can see from deaths that we're now at about 483 deaths per day. That's our 7-day rolling average. We've not really been below 300 deaths a day for a week since last July of 2021. So I don't think that we're going to fall below that point before we go into the high transmission season of September through February. And even if we were to stay at 400 deaths a day, that's a huge number of cases or deaths per year. That would be over 140,000 deaths per year if we stayed at that number. And again, I think that number is going to go up significantly. So probably 4 times to 5 times what the average seasonal influenza death toll is. So we are still nowhere near what somebody reasonably would consider endemic virus state in terms of a normal impact compared to other respiratory viruses. And unfortunately, again, going into the fall, I think we're looking at much higher rates of transmission and unfortunately higher rates of hospitalization and death as our remote vaccines continue to fade into the distance. And so that's what we know. That's what's important to keep in mind as we talk next week, I think, about interventions that we know work to interrupt transmission of the virus in populations. So that's all I have. Thanks, Shelley.